Question 1. A labor and delivery nurse is caring for a 39-week gravida 2 para 1 client who suddenly reports feeling something coming out after spontaneous rupture of membranes. The fetal heart monitor immediately shows recurrent variable decelerations progressing to prolonged bradycardia at 70 beats/minute. On sterile vaginal examination, the nurse palpates a pulsating umbilical cord protruding ahead of the fetal presenting part. The provider is 15 minutes away from the unit. Which nursing action should the nurse implement first? A. Apply oxygen at 2 liters per minute via nasal cannula and continue monitoring. B. Place the client in high Fowler's position and prepare for forceps delivery. C. Insert a gloved hand into the vagina and elevate the presenting part off the cord. D. Increase oxytocin infusion rate to expedite vaginal birth. Answer: C. Insert a gloved hand into the vagina and elevate the presenting part off the cord. Rationale: cord prolapse is an obstetric emergency because compression of the umbilical cord rapidly compromises fetal oxygenation. The priority intervention is immediate manual elevation of the fetal presenting part to relieve pressure on the cord while preparations for emergency birth occur. Oxytocin should be discontinued, not increased. High Fowler's position worsens cord compression. Oxygen may be used later, but relieving compression is the first life-saving intervention. Question 2. A client at 40 weeks gestation is undergoing induction of labor with oxytocin. Following artificial rupture of membranes, the fetal heart rate abruptly decreases from 140 beats/minute to 60 beats/minute and remains there for over 2 minutes. The nurse suspects umbilical cord prolapse. Which additional assessment finding would most strongly support this suspicion? A. Maternal temperature of 38.5 degrees Celsius, 101.3 degrees Fahrenheit. B. Sudden cessation of contractions. C. Visualization of umbilical cord at the vaginal opening. D. Maternal complaint of severe back labor. Answer: C. Visualization of umbilical cord at the vaginal opening. Rationale: visible or palpable umbilical cord following membrane rupture strongly confirms cord prolapse. Persistent fetal bradycardia after rupture of membranes is a classic sign. Fever suggests infection. Back labor relates to fetal positioning, and contractions usually continue unless other complications occur. Question 3. A nurse responds to a prolonged fetal deceleration in a laboring client at 38 weeks gestation. Vaginal examination confirms a prolapsed umbilical cord. Which position should the nurse place the client in to reduce cord compression while awaiting cesarean birth? A. Supine with legs extended. B. Trendelenburg or knee-chest position. C. Semi-Fowler's with left uterine displacement. D. Lithotomy position with elevated head. Answer: B. Trendelenburg or knee-chest position. Rationale: Trendelenburg and knee-chest positions use gravity to shift the fetus away from the pelvis, decreasing pressure on the prolapsed cord. Supine positioning can worsen vena cava compression and fetal hypoxia. Semi-Fowler's and lithotomy do not effectively relieve pressure from a cord. Question 4. A client with polyhydramnios and an unengaged fetal presenting part is admitted in active labor. Which statement by the nurse demonstrates correct understanding of the client's risk for cord prolapse? A. Cord prolapse usually occurs only in post-term pregnancies. B. Polyhydramnios increases the chance that the cord may slip below the presenting part. C. Cord prolapse is unrelated to fetal station. D. Umbilical cord prolapse occurs primarily during the pushing stage. Answer: B. Polyhydramnios increases the chance that the cord may slip below the presenting part. Rationale: polyhydramnios, malpresentation, high fetal station, prematurity, and multiple gestation increase risk for cord prolapse because excess fluid or poor engagement allows the cord to descend past the presenting part after membrane rupture. Cord prolapse is not limited to post-term pregnancies and can occur before pushing begins. Question 5. A nurse is caring for a client with confirmed cord prolapse during labor. Which provider prescription should the nurse question immediately? A. Discontinue oxytocin infusion. B. Prepare the operating room for emergency cesarean birth. C. Apply warm, sterile, saline-soaked towels to exposed cord. D. Attempt to push the prolapsed cord back into the uterus. Answer: D. Attempt to push the prolapsed cord back into the uterus. Rationale: the prolapsed cord should never be manipulated back into the uterus because vasospasm and additional trauma may further compromise fetal circulation. Sterile saline-soaked towels help prevent cord drying if the cord is exposed externally. Emergency cesarean preparation and stopping oxytocin are appropriate interventions. Question 6. A labor nurse identifies variable decelerations that become progressively deeper after rupture of membranes in a client whose fetus remains at -3 station. Which pathophysiologic explanation best supports the nurse's concern for cord prolapse? A. Compression of maternal pelvic vessels reduces placental perfusion. B. Umbilical cord compression decreases fetal oxygen delivery. C. Increased uterine tone causes fetal head molding. D. Maternal hypotension leads to fetal acidosis. Answer: B. Umbilical cord compression decreases fetal oxygen delivery. Rationale: cord prolapse causes mechanical compression of the umbilical cord, reducing blood flow and oxygen transport to the fetus. This rapidly produces fetal hypoxia, bradycardia, and severe variable decelerations. The immediate issue is compromised fetal circulation through the cord. Question 7. A nurse is assisting with emergency management of a prolapsed cord in a laboring client. Which action is appropriate while the nurse's hand remains elevating the fetal presenting part? A. Remove the hand every 5 minutes to assess circulation. B. Maintain continuous upward pressure until birth occurs. C. Encourage the client to bear down during contractions. D. Place the client flat to improve circulation. Answer: B. Maintain continuous upward pressure until birth occurs. Rationale: the nurse must maintain uninterrupted manual elevation of the presenting part until cesarean birth or operative vaginal birth occurs. Removing pressure intermittently can cause repeated cord compression and severe fetal hypoxia. Bearing down worsens compression. Question 8. A client at 37 weeks gestation experiences spontaneous rupture of membranes at home and arrives at the hospital reporting decreased fetal movement. The fetal heart tracing reveals persistent bradycardia. Which maternal history finding most increases the likelihood of cord prolapse? A. Previous cesarean birth. B. Breech presentation diagnosed earlier that day. C. History of gestational hypertension. D. Maternal age older than 35 years. Answer: B. Breech presentation diagnosed earlier that day. Rationale: malpresentation, particularly breech or transverse lie, significantly increases risk for cord prolapse because the presenting part does not effectively fill the pelvis. This allows the cord to descend when membranes rupture. Question 9. During emergency management of cord prolapse, the nurse notes that the fetal heart rate has improved from 70 to 120 beats/minute after repositioning and manual elevation. What is the nurse's priority next action? A. Continue interventions while preparing for immediate birth. B. Remove the hand because fetal status improved. C. Resume oxytocin to restore labor progression. D. Delay surgery to reassess labor progress in 1 hour. Answer: A. Continue interventions while preparing for immediate birth. Rationale: improvement in fetal heart rate indicates temporary relief of cord compression, but the emergency persists until delivery occurs. Continuous decompression and expedited birth remain priorities. Removing interventions risks recurrent hypoxia. Question 10. A nurse educator is reviewing prevention strategies for cord prolapse with newly hired labor nurses. Which situation should the educator identify as requiring the greatest caution during artificial rupture of membranes? A. Fetus at +2 station with engaged vertex presentation. B. Multiparous client with contractions every 2 minutes. C. Unengaged presenting part at -4 station. D. Cervix dilated to 8 centimeters with reassuring fetal tracing. Answer: C. Unengaged presenting part at -4 station. Rationale: artificial rupture of membranes when the presenting part is high and unengaged significantly increases the risk of cord prolapse because the cord can slip below the fetus. Engaged presenting parts help prevent cord descent. Question 11. A nurse is caring for a client in active labor whose fetus suddenly develops severe variable decelerations immediately after spontaneous rupture of membranes. The nurse performs a sterile vaginal examination and palpates a soft, pulsating structure beside the fetal head. Which action should the nurse take immediately after calling for assistance? A. Reposition the client to the left lateral position only. B. Begin chest compressions because fetal distress is present. C. Elevate the presenting part with 2 gloved fingers. D. Insert an internal fetal scalp electrode for more accurate monitoring. Answer: C. Elevate the presenting part with 2 gloved fingers. Rationale: once a prolapse cord is identified, the nurse must manually relieve pressure from the cord by elevating the fetal presenting part. This intervention preserves fetal oxygenation while preparations for emergency birth occur. Internal scalp electrodes may worsen injury, and repositioning alone is insufficient if compression is severe. Question 12. A laboring client at 36 weeks gestation with twins experiences rupture of membranes. The nurse notes fetal bradycardia and suspects cord prolapse. Which factor in this client's history most likely contributed to this emergency? A. Nulliparity. B. Multi-fetal gestation. C. Maternal anemia. D. Epidural anesthesia use. Answer: B. Multi-fetal gestation. Rationale: multiple gestation increases the risk of cord prolapse because fetal presenting parts may not fully engage the pelvis, allowing the cord to descend after membrane rupture. Maternal anemia and epidural use are not major risk factors for cord prolapse. Question 13. A client with confirmed cord prolapse is being transferred to the operating room. Which statement by the nurse best explains the reason for administering oxygen at 10 liters per minute via non-rebreather mask? A. This medication will stop your contractions. B. This helps maximize oxygen delivery to your baby. C. This prevents maternal respiratory alkalosis. D. This treatment will reposition the umbilical cord. Answer: B. This helps maximize oxygen delivery to your baby. Rationale: high-flow oxygen is administered to improve maternal oxygenation and maximize fetal oxygen delivery during episodes of compromised umbilical cord blood flow. Oxygen does not reposition the cord or stop contractions. Question 14. A labor nurse suspects cord prolapse after rupture of membranes in a client whose fetus was previously noted to be in transverse lie. Which fetal heart rate pattern is most concerning for this complication? A. Early decelerations with moderate variability. B. Accelerations after fetal movement. C. Persistent severe bradycardia. D. Sinusoidal pattern without contractions. Answer: C. Persistent severe bradycardia. Rationale: cord prolapse commonly presents with sudden prolonged fetal bradycardia or recurrent severe variable decelerations due to interruption of fetal blood flow through the compressed cord. Early decelerations are generally benign and associated with head compression. Question 15. A nurse is caring for a client with prolapsed cord whose umbilical cord is protruding outside the vagina. Which intervention is appropriate when handling the exposed cord? A. Cover the cord with dry gauze to reduce contamination. B. Apply warm, sterile saline-soaked towels over the cord. C. Push the cord gently back into the vaginal canal. D. Clamp the cord temporarily to reduce swelling. Answer: B. Apply warm, sterile saline-soaked towels over the cord. Rationale: Exposed umbilical cord tissue must be protected from drying and vasospasm by covering it with warm, sterile saline-soaked towels. Dry gauze can damage tissue and worsen fetal oxygen compromise. The cord should never be clamped or reinserted. Question 16. A client with prolapse cord asks the nurse why she is being positioned in knee-chest position during transport to surgery. Which response by the nurse is most accurate? A. This position will stop labor contractions. B. This position decreases pressure on the umbilical cord. C. This position improves the speed of cervical dilation. D. This position allows the fetus to descend faster. Answer: B. This position decreases pressure on the umbilical cord. Rationale: the knee-chest position uses gravity to shift the fetus away from the pelvis and reduce compression on the prolapse cord, helping maintain fetal oxygenation until birth can occur. Question 17. A nurse caring for a client with cord prolapse understands that which outcome indicates interventions have been temporarily effective? A. Maternal blood pressure rises to 150/90 mmHg. B. Uterine contractions become more frequent. C. Fetal heart rate returns to baseline with moderate variability. D. Maternal respiratory rate decreases below 10 breaths/minute. Answer: C. Fetal heart rate returns to baseline with moderate variability. Rationale: improvement in fetal heart rate and variability suggests decreased cord compression and improved fetal oxygenation. However, emergency birth is still required because recurrent compression can rapidly occur again. Question 18. A labor and delivery nurse receives report on 4 clients. Which client should the nurse identify as having the highest risk for umbilical cord prolapse? A. Client at 39 weeks with engaged cephalopresentation. B. Client at 37 weeks with polyhydramnios and breech presentation. C. Client at 40 weeks with gestational diabetes controlled by diet. D. Client at 38 weeks with occiput anterior fetal position. Answer: B. Client at 37 weeks with polyhydramnios and breech presentation. Rationale: polyhydramnios and breech presentation are major risk factors for cord prolapse because excess fluid and poor engagement increase the likelihood of cord descent during membrane rupture. Question 19. During an obstetric emergency drill, a new nurse asks why oxytocin should be discontinued during cord prolapse management. Which response by the charge nurse is best? A. Oxytocin increases uterine contractions and worsens cord compression. B. Oxytocin causes fetal tachycardia during emergencies. C. Oxytocin increases maternal glucose consumption. D. Oxytocin interferes with epidural anesthesia. Answer: oxytocin increases uterine contractions and worsens cord compression. Rationale: stronger and more frequent contractions increase pressure on the prolapsed cord, worsening fetal hypoxia. Therefore, oxytocin infusions should be stopped immediately during cord prolapse emergencies. Question 20. A client undergoing emergency cesarean birth for cord prolapse becomes anxious and asks whether her baby is in danger. Which nursing response is most therapeutic and accurate? A. Everything will definitely be fine, so try not to worry. B. The cord is being compressed, so we are acting quickly to improve oxygen delivery to your baby. C. Your baby is probably already severely brain injured. D. This situation happens often and is not considered an emergency. Answer: B. The cord is being compressed, so we are acting quickly to improve oxygen delivery to your baby. Rationale: therapeutic communication should provide honest, calm, and accurate information. Cord prolapse is a true obstetric emergency because fetal oxygenation is compromised. Reassuring the client that the team is responding rapidly supports emotional coping without giving false guarantees. Question 21. A laboring client at 35 weeks gestation suddenly develops prolonged fetal bradycardia immediately after amniotomy. The nurse identifies a prolapsed cord and manually elevates the presenting part. Which additional intervention should the nurse anticipate the provider may prescribe to further reduce cord compression before cesarean birth? A. Administration of a tocolytic medication. B. Initiation of magnesium sulfate for seizure prevention. C. Encouraging maternal pushing during contractions. D. Immediate ambulation to promote fetal descent. Answer. Administration of a tocolytic medication. Rationale. Tocolytics may be used temporarily to decrease uterine contractions and reduce intermittent cord compression while preparing for emergency delivery. Increased contractions worsen fetal hypoxia. Ambulation and pushing increase pressure on the cord. Question 22. A nurse is preparing to rupture membranes for a laboring client whose fetus remains at -3 station. Which nursing action is most important before the procedure? A. Verify engagement of the presenting part. B. Encourage the client to ambulate before the procedure. C. Administer oxytocin to strengthen contractions. D. Place the client in supine position. Answer. A. Verify engagement of the presenting part. Rationale. An unengaged presenting part significantly increases risk for cord prolapse after membrane rupture. Confirming engagement before amniotomy helps reduce this obstetric emergency. Question 23. A nurse caring for a client with prolapsed cord notices recurrent fetal bradycardia whenever pressure is slightly released from the presenting part. Which interpretation by the nurse is correct? A. Fetal hypoxia worsens when cord compression recurs. B. Maternal hypotension is causing late decelerations. C. The fetus is entering the normal sleep cycle. D. Placental perfusion improves during contractions. Answer. A. Fetal hypoxia worsens when cord compression recurs. Rationale. Recurrent fetal bradycardia indicates ongoing interruption of blood flow through the compressed umbilical cord. Continuous decompression is critical to maintain fetal oxygenation until birth. Question 24. A labor and delivery nurse responds to a prolapsed cord emergency. Which task can the nurse appropriately delegate to an experienced assistive personnel? A. Perform sterile vaginal examination to assess cord position. B. Maintain manual elevation of the presenting fetal part. C. Obtain emergency cesarean delivery equipment and transport supplies. D. Interpret fetal heart monitoring patterns during transport. Answer. C. Obtain emergency cesarean delivery equipment and transport supplies. Rationale. Delegation to assistive personnel should involve non-assessment, non-sterile supportive tasks such as obtaining equipment or preparing transport. Assessment and management of cord prolapse require licensed nursing judgment. Question 25. A client in labor with ruptured membranes develops recurrent severe variable decelerations. Which assessment finding would most strongly suggest occult cord prolapse rather than visible cord prolapse? A. Cord visible outside the vaginal opening. B. Palpable cord protruding through the cervix. C. Persistent fetal bradycardia without visible cord externally. D. Moderate contractions every 5 minutes. Answer. C. Persistent fetal bradycardia without visible cord externally. Rationale. Occult cord prolapse occurs when the cord lies alongside the presenting part but is not externally visible or palpable. Fetal heart abnormalities, such as severe variable decelerations or bradycardia, may be the only clue. Question 26. A nurse is documenting care for a client experiencing cord prolapse. Which documentation entry is most important from a legal and clinical standpoint? A. Client requested ice chips during transport. B. Color of maternal nail polish before surgery. C. Exact time fetal bradycardia began and interventions initiated. D. Number of visitors present during the emergency. Answer. C. Exact time fetal bradycardia began and interventions initiated. Rationale. Precise documentation of fetal status, recognition of the emergency, interventions performed, provider notification, and timing of delivery is critical for continuity of care and medical legal protection. Question 27. A client with a prolapse cord asks why the nurse keeps a hand in the vagina during transfer to the operating room. Which response by the nurse is best? A. I'm trying to rotate your baby into a better position. B. I am preventing pressure on the umbilical cord so oxygen can continue reaching your baby. C. I am checking whether your cervix is continuing to dilate. D. I am preventing rupture of additional membranes. Answer B. I am preventing pressure on the umbilical cord so oxygen can continue reaching your baby. Rationale. Manual elevation of the presenting part reduces compression on the cord and preserves fetal circulation. Explaining interventions clearly helps reduce maternal anxiety during emergencies. Question 28. A labor nurse is reviewing fetal monitor tracings. Which tracing pattern most likely indicates intermittent umbilical cord compression associated with prolapse? A. Early decelerations mirroring contractions. B. Abrupt variable decelerations with loss of variability. C. Accelerations associated with fetal movement. D. Long-term variability with baseline 140 beats/minute. Answer B. Abrupt variable decelerations with loss of variability. Rationale. Variable decelerations are classically associated with cord compression. When severe and recurrent after membrane rupture, especially with loss of variability or bradycardia, prolapse cord should be suspected. Question 29. A client at 32 weeks gestation with preterm premature rupture of membranes is admitted to the labor unit. Which factor places this client at particularly high risk for cord prolapse? A. Immature fetal presenting part may not fully occupy the pelvis. B. Increased placental calcification occurs before term. C. Maternal blood volume decreases during preterm labor. D. Fetal lung maturity accelerates after membrane rupture. Answer A. Immature fetal presenting part may not fully occupy the pelvis. Rationale. Premature fetuses are smaller and less likely to engage firmly within the maternal pelvis, increasing the possibility that the umbilical cord may descend below the presenting part after rupture of membranes. Question 30. A nurse participates in simulation training for cord prolapse emergencies. Which action by a newly licensed nurse requires immediate correction by the instructor? A. Calling for additional assistance immediately. B. Repositioning the client into Trendelenburg position. C. Applying steady upward pressure against the presenting part. D. Leaving the client alone briefly to obtain emergency supplies. Answer D. Leaving the client alone briefly to obtain emergency supplies. Rationale. A client with prolapse cord should never be left unattended because continuous interventions are required to maintain fetal oxygenation. The nurse must remain with the client while other team members obtain supplies and prepare for delivery. Question 31. A client at 38-week gestation experiences sudden fetal bradycardia immediately after standing following spontaneous rupture of membranes. The nurse suspects cord prolapse. Which rationale best explains why position changes may influence cord compression? A. Maternal movement alters placental hormone release. B. Gravity can increase or decrease pressure on the prolapse cord. C. Position changes stimulate fetal lung maturity. D. Maternal ambulation prouvant utérine contraction. Answer B. Gravity can increase or decrease pressure on the prolapse cord. Rationale. Maternal positioning significantly affects the degree of pressure placed on a prolapse cord. Positions such as knee-chest or Trendelenburg reduce gravitational pressure from the fetus on the cord and improve fetal oxygenation. Question 32. A laboring client with a prolapse cord is awaiting emergency cesarean birth. Which assessment finding indicates worsening fetal compromise requiring the most urgent intervention? A. Baseline fetal heart rate of 135 beats/minute with moderate variability. B. Maternal blood pressure of 128/76 mmHg. C. Persistent fetal heart rate below 80 beats/minute despite interventions. D. Contractions occurring every 4 minutes. Answer: C. Persistent fetal heart rate below 80 beats/minute despite interventions. Rationale: persistent severe fetal bradycardia despite decompression measures indicates ongoing critical fetal hypoxia and immediate threat to fetal survival. Rapid operative delivery is essential. Question 33. A nurse is educating a newly hired labor nurse about risk factors for cord prolapse. Which clinical scenario should the nurse identify as highest risk? A. Vertex presentation with engaged fetal head. B. Transverse fetal lie with ruptured membranes. C. Active labor at 39 weeks with intact membranes. D. Occiput anterior presentation at +1 station. Answer: B. Transverse fetal lie with ruptured membranes. Rationale: transverse lie prevents effective engagement of the presenting part in the pelvis, allowing the cord to descend below the fetus when membranes rupture. This creates a major risk for prolapse. Question 34. A nurse caring for a client with confirmed cord prolapse prepares for intrauterine resuscitation. Which intervention is included in this management? A. Increasing oxytocin infusion rate. B. Encouraging frequent pushing efforts. C. Administering high-flow oxygen to the mother. D. Restricting intraveineux fluid administration. Answer: C. Administering high-flow oxygen to the mother. Rationale: intrauterine resuscitation aims to maximize fetal oxygen delivery and includes maternal oxygen administration, repositioning, discontinuing oxytocin for fluid support, and relieving cord compression. Question 35. A client undergoing induction of labor asks why the nurse is carefully monitoring the fetal heart rate immediately after artificial rupture of membranes. Which response is most appropriate? A. The baby may temporarily stop breathing after membrane rupture. B. We monitor closely because cord prolapse can occur suddenly after the membranes rupture. C. Artificial rupture always causes fetal distress. D. The contractions usually stop after the procedure. Answer: B. We monitor closely because cord prolapse can occur suddenly after the membranes rupture. Rationale: cord prolapse is a known risk after rupture of membranes, particularly when the presenting part is high or poorly engaged. Continuous fetal monitoring allows rapid detection of fetal compromise. Question 36. A nurse identifies a prolapsed cord in a laboring client. Which action by the nurse demonstrates correct sterile technique and evidence-based care? A. Covering the exposed cord with warm, sterile, saline-soaked gauze. B. Cleaning the exposed cord vigorously with antiseptic solution. C. Wrapping the cord tightly in dry towels. D. Attempting to push the cord above the fetal head. Answer: A. Covering the exposed cord with warm, sterile, saline-soaked gauze. Rationale: warm, sterile, saline-soaked gauze helps prevent drying and vasospasm of exposed cord tissue while minimizing additional trauma. Manipulating or aggressively cleaning the cord is contraindicated. Question 37. A client with prolapsed cord begins crying and states, "My baby is going to die." Which nursing response is most therapeutic? A. You need to stay calm so the surgery can begin. B. The team is responding quickly, and we're doing everything possible to maintain oxygen flow to your baby. C. You should have come to the hospital sooner. D. Most babies with cord prolapse develop permanent neurologic damage. Answer: B. The team is responding quickly, and we're doing everything possible to maintain oxygen flow to your baby. Rationale: therapeutic communication should provide honest reassurance, emotional support, and clear information without making false promises or blaming the client. Question 38. A nurse notes recurrent severe, variable decelerations during labor. Which additional finding most strongly supports the diagnosis of cord prolapse? A. Maternal complaint of rectal pressure. B. Cervical dilation progressing from 4 centimeters to 6 centimeters. C. Sudden prolonged fetal bradycardia after membrane rupture. D. Maternal pulse increasing from 80 to 90 beats/minute. Answer: C. Sudden prolonged fetal bradycardia after membrane rupture. Rationale: severe fetal bradycardia immediately following rupture of membranes is a classic warning sign of cord prolapse and should prompt immediate vaginal examination. Question 39. A labor nurse understands that prolonged umbilical cord compression can eventually lead to which fetal complication? A. Fetal hyperglycemia. B. Metabolic acidosis and neurologic injury. C. Increased fetal oxygen reserve. D. Accélérité de placentale maturation. Answer: B. Metabolic acidosis and neurologic injury. Rationale: sustained interruption of oxygen delivery leads to fetal hypoxia, anaerobic metabolism, metabolic acidosis, organ injury, and possible neurologic damage or fetal death if delivery is delayed. Question 40. A client experiencing cord prolapse is transported to the operating room while the nurse maintains manual elevation of the presenting part. Which observation indicates the need for continued intervention during transport? A. Fetal heart rate stabilizes only while upward pressure is maintained. B. Maternal respirations are 20 breaths/minute. C. Cervix remains dilated at 6 centimeters. D. Uterine contractions become mild and irregular. Answer: A. Fetal heart rate stabilizes only while upward pressure is maintained. Rationale: if fetal status improves only while decompression is maintained, ongoing cord compression remains present. Continuous manual elevation must continue until birth occurs. Question 41. A labor and delivery nurse is caring for a client with suspected cord prolapse after spontaneous rupture of membranes. Which assessment finding requires the nurse to notify the provider immediately and prepare for emergency intervention? A. Mild early decelerations during contractions. B. Fetal heart rate baseline of 145 beats/minute with accelerations. C. Sudden prolonged fetal bradycardia to 65 beats/minute. D. Maternal report of increasing contraction intensity. Answer: C. Sudden prolonged fetal bradycardia to 65 beats/minute. Rationale: sudden prolonged fetal bradycardia after membrane rupture is a classic sign of severe cord compression and possible prolapse cord. Immediate intervention is necessary to prevent fetal hypoxia and neurologic injury. Question 42. A nurse is assisting with emergency management of cord prolapse. Which action by the nurse best demonstrates appropriate prioritization during the emergency? A. Completing detailed admission documentation before transfer. B. Maintaining manual cord decompression while another staff member prepares the operating room. C. Leaving the bedside briefly to notify family members. D. Delaying surgery until the fetal heart tracing normalizes completely. Answer: B. Maintaining manual cord decompression while another staff member prepares the operating room. Rationale: the priority during cord prolapse is continuous relief of pressure on the cord to preserve fetal oxygenation. The nurse should remain with the client and maintain decompression while the team coordinates emergency birth. Question 43. A laboring client with a prolapsed cord develops repetitive fetal heart decelerations despite maternal repositioning. Which intervention should the nurse implement next? A. Encourage ambulation to improve circulation. B. Initiate manual elevation of the presenting part. C. Increase oxytocin infusion to shorten labor duration. D. Place the client flat in supine position. Answer: B. Initiate manual elevation of the presenting part. Rationale: manual elevation of the presenting fetal part is the definitive immediate nursing intervention to relieve cord compression when repositioning alone is ineffective. Question 44. A client asks the nurse why an emergency cesarean birth is necessary for cord prolapse. Which explanation by the nurse is most accurate? A. The umbilical cord compression can severely reduce oxygen delivery to your baby. B. Cord prolapse usually causes maternal hemorrhage during labor. C. The placenta is separating from the uterus. D. Your contractions are too weak for vaginal birth. Answer. A. The umbilical cord compression can severely reduce oxygen delivery to your baby. Rationale. Cord prolapse compromises blood flow through the umbilical cord, placing the fetus at risk for severe hypoxia, acidosis, brain injury, or death if delivery is delayed. Question 45. A nurse caring for a client with occult cord prolapse understands that which fetal heart tracing characteristic is most commonly associated with this condition? A. Persistent accelerations. B. Recurrent variable decelerations. C. Early decelerations with contractions. D. Stable baseline with moderate variability. Answer. B. Recurrent variable decelerations. Rationale. Occult cord prolapse often presents with recurrent variable decelerations caused by intermittent cord compression, even though the cord is not visible externally. Question 46. A labor nurse is preparing to assist with artificial rupture of membranes in a high-risk client. Which assessment finding should cause the nurse to question the procedure? A. Fetal head engaged at +1 station. B. Cervix fully effaced. C. Breech presentation with high presenting part. D. Contractions occurring every 3 minutes. Answer. C. Breech presentation with high presenting part. Rationale. Breech presentation combined with an unengaged presenting part greatly increases the risk for cord prolapse after membrane rupture. The nurse should communicate concerns before the procedure proceeds. Question 47. A client with confirmed cord prolapse is receiving emergency care. Which nursing intervention is most effective in reducing direct pressure on the umbilical cord? A. Encouraging maternal pushing efforts. B. Elevating the presenting part manually. C. Administering opioid analgesics. D. Applying external heat to the abdomen. Answer. B. Elevating the presenting part manually. Rationale. Manual elevation physically removes pressure from the prolapsed cord and is the most effective immediate nursing intervention for preserving fetal circulation. Question 48. A nurse reviewing outcomes associated with delayed treatment of cord prolapse understands that prolonged fetal hypoxia may result in which complication? A. Neonatal metabolic alkalosis. B. Fetal polycythemia without neurologic effects. C. Hypoxic ischemic encephalopathy. D. Increased fetal oxygen reserve after birth. Answer. C. Hypoxic ischemic encephalopathy. Rationale. Severe prolonged hypoxia from untreated cord compression can cause hypoxic ischemic encephalopathy, permanent neurologic damage, seizures, or fetal death. Question 49. A laboring client with a prolapsed cord is being transferred for emergency cesarean birth. Which statement by the nurse best reflects effective team communication during the emergency? A. Someone should probably call the operating room soon. B. The client has confirmed cord prolapse with persistent fetal bradycardia. Emergency cesarean preparation is needed immediately. C. The fetal tracing looks somewhat concerning. D. We may eventually need provider evaluation if the tracing worsens. Answer. B. The client has confirmed cord prolapse with persistent fetal bradycardia. Emergency cesarean preparation is needed immediately. Rationale. Clear, direct, and specific communication is essential during obstetric emergencies to avoid delays in life-saving interventions. Question 50. A nurse is evaluating the effectiveness of emergency interventions for cord prolapse after delivery. Which neonatal finding would most strongly suggest that fetal oxygenation had been severely compromised before birth? A. Vigorous crying with APGAR score of 9 at 1 minute. B. Umbilical cord blood gases showing severe metabolic acidosis. C. Birth weight appropriate for gestational age. D. Heart rate of 150 beats/minute after delivery. Answer. B. Umbilical cord blood gases showing severe metabolic acidosis. Rationale: severe metabolic acidosis in cord blood indicates prolonged fetal hypoxia and anaerobic metabolism prior to delivery. This finding suggests significant compromise from cord compression.